Welcome to week 2 of CAA322. So this week will be a bit of a revision week of core topics covered in other units. And we do this because it's really important that we have this sound understanding of the foundations of ECG interpretation, cardiac anatomy, physiology and electrophysiology prior to moving on to 12 leads and the associated conditions that we're looking for on the 12 lead ECG. In the lecture this week we'll be covering cardiac anatomy and physiology, the associated electrophysiology and the basic ECG components and their interpretation in a single lead format. And by the end of this module, you should be able to identify key components of a single lead ECG tracing, including waveforms, segments and intervals, describe the electrophysiological structures involved in the creation of ECG waveforms, and describe the electromechanical function of the heart, identifying the anatomical structures involved. So now let's have a look at the gross anatomy of the heart and its associated great vessels. So basically where it sits in the chest or thoracic cavity and what landmarks surround it. Understanding these structures' spatial relationships is really essential for accurate clinical examination, diagnosis and treatment planning. So if you think to things like palpating the apex beat, you need to know the anatomical landmarks that allow you to do that accurately on a patient, and also things like ECG electrode placement. So being able to find the correct intercostal space is paramount for obtaining an accurate ECG reading. The heart itself is situated in the middle mediastinum and it occupies the space between the two lungs. It lies what we refer to as obliquely, with 2/3 of its mass positioned to the left of the midline and approximately 1/3 to the right. The heart's apex points towards the left side, and it's typically at the level of the 5th intercostal space, around 7 to 8 centimetres from the midline. So the heart essentially extends from the right sternal border through to the left midclavicular line. The aorta arises from that left ventricle and arches posteriorly to the left. It descends through the thoracic cavity, giving off branches that supply things like the chest wall and key visceral organs. The superior vena cava sits at approximately the same level as the aortic arch and ascends upwards. The inferior vena cava enters the right atrium through that inferior portion. We also need to discuss some of the key surrounding structures that we use as anatomical landmarks in that thoracic cavity so we know exactly where that heart sits. The sternum is a flat bone in the midline of the chest, and this serves as a really important reference point for locating the heart and the great vessels. The manubrium, which is the upper part of the sternum, articulates with the clavicles and the first rib. The angle of Louis, which is also known as the sternal angle, is located at the junction of the manubrium and the body of the sternum. And this landmark corresponds to the level of the second rib and can be used to count rib spaces and locate the heart position. And as I mentioned before, this comes in really handy knowing this anatomical landmark for when you are placing ECG dots on the patient. So as we know, the heart is critical to survival. It generates blood pressure, regulates blood supply to meet metabolic needs, so it can change the rate and force of its contractions, and it ensures a one-way flow of blood throughout the vasculature. It's essentially a dual circuit muscular pump, so it supplies both pulmonary and systemic circulation. So if we track the flow of blood, starting with deoxygenated blood, we can see that deoxygenated blood returns through both the superior vena cava and the inferior vena cava into the right atrium. Upon contraction, that blood will flow into the right ventricle through the tricuspid valve. Upon contraction, the right ventricle blood will enter the pulmonary arteries through the pulmonary valve, and it will go off to pulmonary circulation to undergo gaseous exchange, where it will become oxygen enriched and the carbon dioxide will be expelled. The oxygenated blood returns to the heart through the pulmonary veins and it enters the left atrium. Upon contraction of the left atrium, or of the atria in general, the oxygenated blood will be moved through the left ventricle through the mitral valve. And then from left ventricular contraction, blood will go through the aortic semilunar valve and into the aorta through to systemic circulation. So now let's take a little bit of time to review coronary circulation. And coronary circulation originates from the left and right coronary arteries. The left coronary artery arises from the base of the aorta just before the left coronary cusp of the aortic valve. The right coronary artery arises from the aorta just above the right aortic coronary cusp. The coronary arteries are really important as they supply the myocardial cells with blood. So this is the way that the heart perfuses itself. And amongst all organs, the heart's unique in that oxygen extraction is constantly close to maximal at all times. So the only way that this metabolically demanding organ can increase oxygen consumption is by increasing coronary blood flow. And this is done by dilating the coronary arteries. The right coronary artery supplies the right atrium and the right ventricle through the marginal branch, and the inferior side of both right and left ventricles through the posterior intraventricular branch, and also supplies the sinoatrial node as well. The left coronary artery divides into the left anterior descending artery and the left circumflex artery. They supply the anterior and lateral wall of the left ventricle and the septum as well. The left anterior descending artery supplies the right bundle branch and the left anterior fasciculus of the left bundle branch as well. The circumflex artery supplies the posterior fascicle of the left bundle branch, and this becomes important when we start to look at bundle branch blocks on an ECG. It's also worth mentioning that about 10% of the population have the inferior side of their heart supplied by the left circumflex artery, not the right coronary artery. The marginal branch of the right coronary artery supplies the anterior surface of the left ventricle. This is known as a bit of an ECG blind spot, and this is why we add right-sided leads if we suspect a right anterior infarct. So, as we mentioned on the previous slide, the heart's unique because it needs to perfuse itself. And essentially during systole, so when the heart contracts, it squeezes the openings of the coronary arteries in the coronary sinus shut. So it's only during diastole that the coronary arteries become patent again, and this is when it allows blood to flow under that sitting aortic pressure into the coronary arteries, capillaries and coronary veins. So this is known as coronary perfusion pressure, and it's essentially the difference between the diastolic pressure in the aorta and the diastolic pressure in the right atrium, creating a pressure gradient which results in coronary blood flow. This is important clinically as in cases of tachycardia, there's less time spent in diastole, so the heart is at rest for much less time. And this allows essentially for a reduced time for that coronary blood flow to occur, and hence a bit of an increased risk of tissue ischemia. It's also the reason that adequate diastolic blood pressure is critically important, really. As we touched on briefly, the heart has 4 valves which open and close in a regular and synchronized pattern to allow both the heart to fill with blood and then ejects that blood into both the lungs and systemic circulation. The 2 atrioventricular valves are the tricuspid valve and the bicuspid or mitral valve. And these allow blood to flow from the atria into the ventricles. The two semilunar valves, they're called semilunar valves because of the half-moon type crescent shape of the valve leaflets, are the aortic valve and pulmonary valve. You also might hear of these mentioned as the aortic semilunar valve or pulmonary semilunar valve. These valves open during systole, and the contraction of the ventricles pushes blood through them into both pulmonary circulation and systemic circulation. The heart wall itself is made up of 3 layers, and these are the epicardium, which is the outermost layer, the myocardium, which is the main muscle mass of the heart, so that big thick middle layer, and the endocardium, which is the innermost layer of the heart and lines that lumen of the chambers. It's really important that you understand these layers, because when we talk about things like STEMIs and acute myocardial infarctions, we're talking about the damage that it actually does to the heart. So, for example, if we highlight a transmural infarction, we know that it's a full thickness infarction that does involve all 3 layers. So having a sound understanding of this anatomy is really important.
So we can notice a few things when looking across the transverse plane of the heart. Take particular note of the thickness of that left ventricular wall and the septum compared to the right ventricular wall. This is important when we discuss the electrical flow through the heart and how ECG electrodes see this flow. The electrical signals picked up by the ECG are dominated by that left ventricle and septum, which override the much weaker signal generated by the right wall. This makes identifying problems with the right ventricular wall a little bit more challenging. Not pictured above, but it's important to note too that the atria also have relatively thin walls, therefore they generate much weaker electrical signals. So the heart itself sits within a fluid-filled sac known as the pericardium. This sac allows the heart to beat freely, but to also anchor it to surrounding structures so it doesn't move around too much in the chest. So this double-sided pericardial sac provides protection as well and contains lubricating pericardial fluid, around 10 to 20 mils. You'll notice that the map of the electrophysiological aspect of the heart may not be as detailed as ones you've seen, but we'll work on this one just for the revision purposes. So electrical impulses are generated by the sinoatrial node at an intrinsic rate of around 60 to 100 beats per minute. The sinoatrial node is the dominant pacemaker site. The impulse is then transmitted throughout the atria via the internodal tracts in the right atrium and Bachmann's bundle in the left atrium. This causes both the atria to contract simultaneously. The impulse then flows to the atrioventricular node located in the inferior right atrium, where it's delayed by about 0.04 seconds to allow the contraction of the atria to completely fill the ventricles. The atrioventricular node is also capable of generating impulse, although at a slower rate of around 40 to 60 beats per minute. This rate, however, is normally overtaken by the faster sinoatrial rate. If no signal is received from the sinoatrial node, most often due to ischemic changes, then the AV node will become the primary pacemaker, and we'll see a junctional rhythm on the ECG. We'll look at this later when we start analysing 12-lead ECGs. However, junctional rhythms usually have no P waves, so no atrial waves, or they may have an inverted P wave. After leaving the AV node, the impulse travels through the atrioventricular septum via the bundle of His, which then splits into the left and right bundle branches. The left bundle branch further divides into the left anterior and left posterior fascicles. The left anterior fasciculus extends through the anterior wall of the left ventricle, and the left posterior fasciculus extends through the lateral and posterior portions of the left ventricle. Moving down, the Purkinje fibres extend from the bundle branches deep into the myocardial tissue, causing contraction of ventricular cardiac cells and therefore ventricular contraction. Purkinje fibres are also able to generate a pacemaking rhythm, but the intrinsic rate is quite low, around 20 to 40 beats per minute. This will only be the dominant pacemaker site in an absence of any impulse from either the sinoatrial node or the atrioventricular node, or a blockage at the bundle of His.
So let's now move on to the revision of ECG type basics. We'll start with ECG paper, and ECG paper is marked with a small grid of squares, and each is 1 millimetre by 1 millimetre. You'll also notice there are additional darker lines, and they group these squares into larger squares, so each is 5 millimetres by 5 millimetres. ECG paper feeds through an ECG monitor or machine at a default speed, and it's universal, and this is 25 millimetres per second. And this means that we can use the horizontal axis to measure the time between the cardiac events recorded on the paper. And this is of critical importance when we interpret an ECG readout, as it gives us information about how fast or how slow the heart is beating. It also tells us if it's beating regularly or irregularly, and if all the events that should be occurring according to the electrophysiological aspect are actually occurring mechanically. And if they are, it should tell us if there are any delays as such. So all of this information helps us decide if the patient's heart is functionally normal or abnormal, and it also tells us the degree, or can tell us the degree, of abnormality. So essentially, are they critically ill? Back to the small squares, and each small square represents 0.04 seconds. Each large square represents 0.2 seconds. It's therefore that it follows a pattern that each 5 large squares represent 1 second. So 5.2s of a second equal 1 second. 15 large squares represent 3 seconds, and so on. Most ECG paper will have some sort of mark at the top of the paper, usually at 1 second intervals or at 3 second intervals. The vertical distance on the ECG paper indicates voltage of the electrical signal. When calibrated correctly and set on the machine's default setting, one small square in the vertical direction represents 0.1 millivolts. With this in mind, 10 small squares equals 1 millivolt in amplitude.
This diagram shows the cardiac electrical activity that correlates with the waveforms on the ECG readout, and it's taken from the perspective of lead 2. So if we follow it through, atrial depolarization initiated by the SA node causes the P wave. With atrial depolarization complete, the impulse is delayed at the AV node. Ventricular depolarization begins at the apex, causing the QRX complex. Atrial repolarization then occurs, and atrial repolarization will be hidden in that QRS complex. Ventricular depolarization is complete, and then ventricular repolarization begins at the apex, causing the T wave. Ventricular repolarization is then complete. So this diagram shows a few different things. It shows that for any electrode, a depolarizing current flowing towards that electrode will cause a positive deflection, and a depolarizing current flowing away from the electrode will result in a negative deflection on the ECG tracing. The opposite is true for repolarizing current. So repolarizing current flowing toward the electrode will result in a negative deflection. Repolarizing current flowing away from an electrode will result in a positive deflection. This pattern of deflection of the waveform is why different leads in a 12-lead ECG will have different shapes. So just remember that they're looking from the heart from different angles. This diagram shows the overall direction of charge from the lead 2 perspective. Note that if a depolarizing current is flowing toward the lead, the deflection is positive. If the depolarizing current is flowing away from the lead, the deflection is negative. If the current is flowing at the right angle to the lead, the resultant wave will either show up as an up-down deflection, or there'll be no deflection at all. So if we have a look at that middle section, we can see that equiphasic pattern. This overall flow of the current is actually the summation of many smaller currents flowing in different directions throughout the septum and the ventricles. This overall direction of charge is called the cardiac axis, and in a normal heart flows in a direction close to 60 degrees from horizontal. We'll cover cardiac axis later in the semester in weeks 4 and 5. A quick review of the leads that we already know before we move on to the 12-lead ECG later in the semester. So we've got bipolar limb leads, and these measure the voltage between pairs of limbs. So lead 1 measures the voltage between the right arm and the left arm, lead 2 between the right arm and the left leg, and lead 3 between the left arm and the left leg. Unipolar leads, or augmented vector leads, they measure between the heart and a single limb lead. So the heart is used as a zero reference point.
So on screen at the moment you will see an example of a basic science rhythm, and it's segmented to show some of the key waveforms, intervals and segments. So we'll go through a few of these just to jog your memory. The P wave represents depolarization of the atria following SA nodal triggering. The QRS complex represents depolarization of the ventricles, and this happens after that depolarization wave follows down and exits the bundle of His. Then we have the T wave, which represents ventricular repolarization. Atrial repolarization cannot usually be seen on an ECG tracing, as it occurs simultaneously with ventricular depolarization. And if we think back to a couple of slides ago, we're looking at the result of that dominant mass of the ventricles as opposed to the atria. So it's creating a much more dominant electrical signal, which is represented as a QRS complex, and it's hiding that atrial repolarization. The PR interval encompasses both atrial depolarization, which is represented by the P wave, and the slight delay of the AV node, which allows the filling of the ventricles. The QT interval starts with the depolarization of the ventricles and ends at the end of the T wave or once they've finished repolarizing. The ST segment represents the beginning of ventricular repolarization, and this should be flat and isoelectric.
If we have a closer look at the P wave, it's a graphical representation of atrial depolarization. With normal physiology, this is initiated by the SA node. The P wave can tell us many different things. A normal P wave followed by a normal QRS lets us know that the patient has normal conduction, which is originating from the sinoatrial node. A normal P wave has the following characteristics. It precedes the QRS complex. It's 2 to 3 millimeters high. It has a duration of approximately 0.06 to 0.12 seconds, about 2 to 3 small squares. It's rounded and upright in lead 2. And the absence of a P wave lets us know that the pacemaker is somewhere else in the heart. When individual muscle fibers contract in an uncoordinated manner, they're said to be fibrillating. Fibrillation can occur in both atrial and ventricular muscle. Atrial fibrillation is the most common sustained arrhythmia, with a lifetime risk over the age of 40 years of around 25%, and this is currently increasing. Complications of AF include hemodynamic instability, cardiomyopathy, cardiac failure, and embolic events such as stroke. When the atrial muscle fibres contract independently, there's no P waves on the ECG, only an irregular line, as we can see on the example on screen. The AV node is continuously bombarded with depolarization waves of varying strengths, and depolarization spreads at irregular intervals down the bundle of His. The AV node conducts in an all or none fashion, so that the depolarization waves passing into the bundle of His are of constant intensity. Because these waves are irregular and the ventricles therefore contract irregularly to match this, because conduction into the ventricles is by the normal route, each QRS is of normal shape. The PR interval, as highlighted by the blue circle on screen, is measured from the beginning of the P wave to the beginning of the QRS complex. And don't forget to review the difference between an interval and a segment. The PR interval should be between 0.12 and 0.2 seconds in duration, or 3 to 5 small squares. The PR interval tracks the atrial impulse from the SA node through the atria, through the AV node, the bundle of His, and the bundle branches. Short PR intervals, so less than 0.12 seconds, are associated with rhythms generated from somewhere other than the SA node, and these are generally junctional rhythms. Prolonged PR intervals, so greater than 0.20 seconds, usually represent a delay in conduction, which is known as a heart block. Heart blocks can be at any level of the electrical conduction system in the heart. The ECG on screen shows a prolonged PR interval, so one that's greater than 0.20 seconds, and this indicates an atrioventricular block. In the case of the ECG above, this is a first degree AV block. We'll discuss these more later in the semester. The QRS complex follows the P wave and represents the rapid depolarization of the ventricles. Remember that the ECG shows only electrical activity, not the actual mechanical activity of the heart. So the QRS complex appears just before the ventricles contract. And the electrical activity doesn't always mean that there's actual mechanical activity. The contractions could be weak or even absent in cases such as PEA or pulseless electrical activity. So it's always important to treat the patient and not just the monitor. The Q wave represents left to right septal depolarization. Q waves are typically seen in the left-sided leads 1, AVL, V5 and V6. The QRS complex may have varied morphologies. So some nomenclature of the QRS complex. If the first deflection is negative, it's called the Q wave. Any positive deflection is called an R wave. Any negative deflection following an R wave is called an S wave. And remember that there may be more than one R wave. If we have a look on screen, we can see some RSR patterns, and we'll discuss these later on when we look at conduction delays due to bundle branch blocks. The ST segment is the flat isoelectric section of the ECG between the end of the S wave, or the J point, and the beginning of the T wave. It represents the interval between ventricular depolarization and repolarization. The most important cause of ST segment abnormality, so either elevation or depression, is myocardial ischemia or infarction, although there are a number of other causes to ST segment changes. We'll learn about the ST segment analysis later on. The T wave is the positive deflection after each QRS complex and represents ventricular repolarization. A T wave is normally rounded and smooth and about 0.5 millimeter high in leads 1, 2 and 3, but it can be up to 10 millimeters high in leads V1 to V6. A normal T wave is usually in the same direction as the QRS complex, except in the right precordial leads. In the normal ECG, the T wave is always uprights in lead 1, 2 and V3 to V6. The T wave's always inverted in ABR. The T wave is quite labile and it can change easily. And there's many possible causes of T wave changes. A changing T wave may be a sign that something is abnormal. However, it may also be just a normal variant, especially in children. T waves can be peaked, normal, flat, or negative. Some possible causes of T wave changes include infarction, hyperkalemia, persistent juvenile T wave pattern, myocardial ischemia and infarction, bundle branch blocks, ventricular hypertrophy, pulmonary embolism, hypertrophic cardiomyopathy, and raised intracranial pressure. The ECGs above show hyperacute T waves, and these changes are normally associated with an early anterior STEMI presentation. The QT interval is the time from the start of the Q wave to the end of the T wave. It represents the time taken for ventricular depolarization and repolarization. The length of the QT interval varies with the heart rate, so a faster heart rate results in a shorter QT interval. An abnormally prolonged QT is associated with increased risk of ventricular arrhythmias. The QT interval should be measured in lead 2 or in lead V5 or V6. A useful rule of thumb is that a normal QT is less than half the preceding RR interval. The ECG on screen shows an instance of QT interval prolongation. There's many possible causes of this, and these include hypokalemia, hypocalcemia, hypothermia, myocardial ischemia, post-cardiac arrest rhythms, raised intracranial pressure, congenital long QT syndrome, and various drugs. A normal QT interval should be between 0.366 and 0.44 seconds. This depends on age, sex, and heart rate.
So in CAA322, as we've moved on from single lead interpretation, we'll be using a slightly different method when applying it to 12 lead ECGs. We will, however, now go through a revision of this basic 5-step method, which most of you will be familiar with. These steps in this method are still highly important as they still carry over to that 12 lead interpretation, so we don't forget them completely. Essentially, we just add more things when we apply them to the 12 lead ECG. If we start with rate, we'll see that there are a plethora of options for determining the rate of an ECG. And some of these include the 6-second method, the RR interval method, the rate calculator ruler method, and the rule of 300 method. And we'll discuss some of these in a bit more detail in the coming slides.
The 6-second method is the simplest and the fastest, but it's the least accurate. It can be used for regular and irregular rhythms. If the heart rate is really slow or irregular, then you may have to count over 2 6-second periods. Have a look on the screen at the moment and see if you can work out what the heart rate is.
There's the RR method of determining rate, and this is also a relatively quick and easy method for determining the rate on an ECG. So what we need to do with the RR method is to count the large squares or each 0.2 second interval between the two R waves and then divide by 300. So if we look at the example on screen, there's approximately 3 large squares in between each R wave. So it would be 300 divided by 3, which gives us a rate of around 100 beats per minute. There's also the 300 method for determining rate. And this is done by picking the dark line that's close to the R wave. So if we have a look at that first QRS complex on the example on screen, we can see that it pretty much sits on the border of one of those larger boxes, or one of the dark lines. So from here, you need to count the number of dark lines until the next R wave using a specific system of numbers. And these are on screen at the moment, so 300, 150, 100, 75, and so on. Now, if we look at applying that method to the ECG on screen, we use those first two complexes as an example as they line up on a dark line or close to it. So we can see that there's 1, 2, 3, 4. It finishes on the fourth dark line. So if we count them, we've got 300, 150, 175. So the heart rate for this ECG or this rhythm would be 75 beats per minute. The next step is to determine the regularity of the ECG. And this is done by first measuring an RR interval. So pick an RR interval or a few, and you can measure them with either ECG calipers, or you can put a piece of paper up to the RR interval and mark it on that piece of paper, and then slide it along to the next interval or the subsequent intervals and see if it matches and remains similar. It won't be 100% the same each time just due to natural variances, but if it's within a small box or two, you can be pretty confident in saying that rhythm is regular. Step 3 requires us to assess the P wave. So we need to look at its morphology, duration and amplitude. So for a P wave, they should be between 0.5 millimeters to 2.5 millimeters in height, or half a small box to 2.5 small boxes. And they should be no more than 0.1 seconds or 10 milliseconds in duration. The morphology should be rounded and upright, and variations can include notch P waves, which are termed P mitrale, and they may indicate left atrial enlargement. You may also come across peaked P waves, and this can be termed P pulmonale, and this may indicate right atrial enlargement.
After we look at the P wave, we can have a look at the PR interval and the AV conduction ratio. The PR interval we know is important because we know that if it's prolonged, there may be some associated heart block. We also want to know what the AV conduction ratio is. So how many P waves are there to QRS complexes? Is it a 1-to-1 as it normally should be, or is it more? Are there 2-to-1? Is it regular or irregular?
The next step is to identify and assess the QR complex. And we need to be looking at things like, is the QRS complex of a normal duration? So a normal QRS complex in a healthy adult will probably be somewhere between 0.06 seconds and 0.10 seconds, although the borderline for normal versus abnormal can be debatable depending on the text that you read. Some have it down at 0.10 seconds, whereas other texts have it at 0.12 seconds. We're also looking for amplitude, so is it a normal amplitude? The amplitude of an ECG should be greater than 0.5 millivolts in at least one standard limb lead. And in precordial leads, it should be greater than 1 millivolt in those leads as well. It's also really useful to describe the morphology of a QRS complex. So on the screen at the moment, we have quite a nice normal looking QRS complex with a deep S wave. It's really useful to describe the pattern. So is it a biphasic pattern? Does it have the rabbit ears type pattern? And this is really important because certain type of blocks can cause those different morphologies and changes to those morphologies, and we'll cover those a bit more later in the semester when we move on to bundle branch blocks. But for this point in review, it's really useful just to describe the morphology. After gathering all of our information from going through those 5 steps systematically, we now need to use that information to form a diagnosis of the rhythm. And this is essentially where we give the rhythm a name. So for example, the rhythm on screen would be called atrial fibrillation. Following on from this, once we know what the rhythm is, we can now start to determine the clinical significance of the rhythm. And this is really important because whilst we may get caught up in these lovely squiggly lines and working out what they mean, we need to actually link it to the anatomical structures in the heart. So, for example, if you determined that the rhythm is a ventricular escape rhythm, what does that mean? What's actually happening? If we use that as an example, we know that the origin of the rhythm is coming from an ectopic pacemaker site from somewhere within the ventricles. We know that the inherent rate of firing of the ventricles is less than 40 beats per minute, meaning that it's not a sustainable rhythm. By understanding these type of features, we know that we can intervene prior to the patient becoming unconscious or going into cardiac arrest. So I guess, as you can see, a holistic understanding of both ECG and the underlying structures they represent, or what the ECG represents, is really, really important for adequate provision of patient care. So thank you all for listening this week. I hope that this revision has been a good way for you to go back and have a look at some of those core concepts covered previously. Hopefully that will give everyone a sound understanding and a really good foundation to build upon in the coming weeks when we move on to 12-lead ECGs and different cardiovascular pathologies.